Welcome to SIF 2023, back again here with Chadi Alraies. He's going to be talking to us today about mechanical circulatory support in shock. We're very happy to be back in the desert, so welcome.
Thank you, Jonathan. Always a pleasure.
So you had an interesting case. Tell us a little bit about it.
Yeah, sure. I mean, so as you know, 20% of SEMI patients have some sort of shock. Some of them are more fluid shock than others requiring pressors. So as an interventionist taking STEMI calls, you have to be very vigilant about your equipment, what you have in the lab, and how quickly you can escalate. One thing is very important to keep in mind is, number one is your access. You have to be very familiar with access. But two, also you have to have your connection, who's running the ECMO program in your hospital. This is an advice for people coming to the job now, and who's running the ECMO process. So in the last 6 months, we had kind of a handful of patients, almost 6 patients, coming with a fluid shock. But there's a kind of questionable evidence for LV thrombus, and that took the Impella option out. So the question comes, when do you call the surgeon and how? Now, one of the kind of the denominator for these cases is patient kind of hypotensive, they have 1 pressors. As soon as you start pushing to the second pressor or lactates start to go above 4, I think that's an indicator that this patient not going to make it with 2 pressors, because that's going to mean some kind of MCS. And if you have a contraindication for Impella or a tandem heart, whatever device you have, I think you should pull a trigger on ECMO. And as we know from registry data and from previous study as well, ECMO can be used as an oxygenator as well as for circulation support. So in our cases is after calibrating the patients, you have the heart team approach, we have a cardiologist rounding from cardiology standpoint, because you have to make sure the antiplatelet is going, because this is what the surgeon don't like usually for antiplatelet, and also the anticoagulation properly done for avoid any chugging. So the bottom line is to understand what you have on the shelf, and 2, when and how to insert these devices, and 3rd is how to manage these patients and how to wean them up.
For sure.
So one of the major registries that we have, which is the National Cardiogenic Shock Initiative, is looking at 2 metrics, which is the CPO, cardiac power output, as well as lactate. If your number is less than 0.6 for CPO or if lactate above 2, then you are still in the area where you shouldn't be waiting.
Right.
Our protocol in the ICU is if the patient have a weanable or blood pressure is getting better and he or she can be weaned, so we do what's called weaning trial in ECMO or Impella, and then we agree if the heart recovery and heart squeezing strong enough, then last time can be decalibrated safely.
For sure. So I'm curious, oftentimes, these patients are showing up middle of the night. You're the only one there, at least at the moment.
Yes.
You can always call your team, but it takes a little while to round everybody up.
Yeah.
What's your process in terms of, sometimes it's confusing, do you do the right heart cath first, do you get access, do you shoot the coronaries first, do you put the circulatory support in first? How do you approach that?
Well, I mean, we still don't have an answer for that, and so far what the guidelines feed us is door to balloon time, and this is you have to open the artery. There's a lot of DTU, door to unload kind of trial. It has kind of pilot trial of handful of patients published at Circulation, but it's still, right now, the standard of care is to open the artery. So what we usually do, we go and treat the culprit, and then if there's any hemodynamic issues, you drop the pigtail, you do LVEDP, and then if there's some sort of shock, you do right heart cath, and then you calculate your numbers to see if you are heading towards MCS or you need to kind of wait till this hemodynamics can get more compromised or get better.
Right.
So this is usually our algorithm, and then you can call the device, depends on what you have available on the shelf, patient access, as well as how much support you need.
So we're just hearing about some new devices here. As we go forward, we're having more and more options.
Yeah.
What's something, do you have like a general one you go to all the time? Is it sort of, I imagine it's somewhat patient specific, whether you choose MCS or ECMO or both.
Right.
What's your usual process?
So it's driven by as you said, multiple factors. There's a hemodynamic factors, there is a patient comorbidities factors, there is also lab factors, if the patient is hemolyzing or something else, or anemic, for example, or if there is respiratory component into it. So we know if there's a respiratory component to the shock and patient in floor-pulmonary edema, you're intubated. So maybe that VA ECMO would be a good option because you're hitting 2 birds in 1 stone. Now we have to ventilate the LV. You might need to do an Impella kind of to ventilate the LV, but again, Impella can be the go-to. This is the quickest, kind of most interventionalists are familiar with, as long as you have a safe access protocol, that's what you need to be familiar with, and your staff and faculty in treating patients are familiar with that access.
For sure. You mentioned the care of the patient after the cath lab was obviously key to their survival and outcomes. And sort of more and more often now we're hearing about these shock teams and where you're involving the surgeons and the heart failure specialists. How have you found that that's affected your care for patients?
Absolutely. You have to it's a brainstorming. It's like a grand round every day happen on the patient about what medication should be on, when to wean, what kind to wean to mechanical support to another mechanical support, and for sure eventually is the medication that the patient started on. As cardiologists, we can guide and help with the hemodynamic monitoring the surgeon to see how much support needed, but also weaning has an art into it, and there is very limited literature about the weaning and how every institution have developed their own weaning protocol. It's kind of everybody collect data from other institutions, but the bottom line, as I mentioned, the two parameters that we look into usually is the CPO and lactic acid. And then as you're weaning, also you have to make sure the antiplatelet is on board, don't miss it, and if there is a risk for bleeding, then you have to know what bridge. Maybe you should consider Cangalore and while giving PTY12 inhibitor till the patient more stable, so the surgeon comfortable, or you are comfortable pulling these devices out.
Yeah, you actually hit on my next question with it before I even brought it up, but sometimes we found at our institution there's some trouble with bleeding from the access sites, and this is a problem because you've just placed a stent potentially somewhere dangerous. How do you manage the balance of bleeding versus keeping your stent open?
Yeah.
Does it vary at all based on where the stent was placed and the size of the vessel?
Right,
Do you have a general rule, or how do you approach that?
Well, it's funny you mentioned that. Just on Monday we had such a STEMI in a big circ. We ended up putting a 4.0 and 3.5, kind of a long left circumflex OM. So if the vessel is big and you are really have a good perfusion, and the patient ended up going for ECMO. And the problem, because he came as a cardiac arrest, there was some CPR happened before, then they have a large hemothorax, and he lost almost 5 grams of hemoglobin, requiring a lot of transfusion. Here you have no question, you have to stop it. So, but the surgeons are comfortable keeping the aspirin on. I know you are giving platelets, you are giving out blood products, which can contradict your antiplatelet, but still they were okay giving aspirin. And I think the size of the vessel matters, and we know you have good stent, we eye visited, we make sure the stent is opposed. I know it's acute, and we kept an eye on the patient hemodynamics. You have no choice at this point. The bleeding outweigh. But now the patient is decannulated, he started to take NG medication, so anticoagulation was started. But here we started with a less potent PTY12 inhibitor. So we switched him from ticagrelor to clopidogrel.
Makes sense. Okay. Well, we're getting to the end here, so I think more and more we're being able to save some patients that before we kind of thought were unsavable.
Yes.
Where do you see the future going as we try to save more and more sick patients as they come to us?
I mean, the field is growing. We have a lot of options on the shelf, and the research is happening. As you mentioned, there's new devices coming that SIF presenting, like a groundbreaking Shark Tank kind of ideas coming up. The most important thing is early recognition of shock, and two is to know what equipment you have and use what you are comfortable with. But don't get stuck in these kind of limited resources that usually the hospital can provide for you. Usually if something can be beneficial, has a better outcome, push your administration to purchase these things or hire people who can help you with building these teams. So I think the future is still, we have a lot of work to be done. And as you know, Center of Excellence are only a handful in the States. So if we can kind of give more kind of leverage to other centers, have a lot of sick patients, but they don't have access to the protocols that we have, I think would be a good thing to do going forward.
Completely agree. Chadi, always a pleasure.
Thank you so much.
Thank you. Stay tuned for more from SIF 2023.